Dr. Greenberg, I'm really looking forward to having this conversation. There are so many patients that come to me and talk about their child's tics, and they want to know what to do, how to proceed, should they do anything. And so I'm happy to have you here to help give patients good information to help guide them appropriately.
Yeah, absolutely. Happy to be here and happy to be speaking about this topic, which is near and dear to my heart and everyday practice.
So to start, will you tell us a bit about yourself? Where do you work and what kind of work do you do?
Yeah, so I'm in Boston. I'm the director of the pediatric psychiatry OCD and Tic disorders program, where we have a small, robust clinical program with about 4 staff that we see children anywhere between ages like 3, 4 up to usually 18, maybe a little higher, who present with either tics and or obsessive compulsive disorder. And those two we see pretty commonly together, and or any of the common conditions that we often see in kids who have tics or OCD.
And I'm curious, what drew you to work with kids with tics and OCD? Was there anything in particular that happened in your life, or is it something that just has always interested you?
Yeah, so I was always interested in the interface between psychiatry and neurology. And just in general, that area had always been highly interesting to me. And I had always enjoyed working with kids and kid populations. And then more specifically towards Tourette, my younger brother was diagnosed with it when I was in high school and then early parts of college. And so I saw his experiences, learned from him. I had my own experiences as a sibling. I saw my parents have their experiences in terms of a new diagnosis that, at least back then, certainly carried a lot of stigma, and how they navigated it. And he's grown over the years into a great young man, but it kind of gave me a foray into the field. And so I did my medical training at Cornell in New York City, and then I did my residency in psychiatry training in Harvard Longwood in Boston, and then my child fellowship in Mass General McLean in Boston. And then shortly after graduating, I've been doing this full time.
It's fantastic. So it sounds like you're really well trained. And also, I'm sure that your experience with your brother has made you an extra compassionate doctor. So how lucky for your patients.
Well, I try, but yes, everyone's experience is different and unique, which I think is always super important, never to assume that I will understand something just because I've seen it in my family or in other patients. But I think it helps give a little bit of an extra lens of that proxy lived experience that is hopefully helpful.
Absolutely. And I have to tell you, I feel like a podcast on tics and Tourette's is really long overdue because it's something that comes up so frequently in my office and causes so much stress for families. So I think getting an overview and getting a deeper understanding about what they are, what the natural course of tics to be expected will be, and what parents can actually do about it, I think will be really helpful. So very grateful for your time.
No, absolutely. And I'm happy to be sharing about it. And I think to your point, once you know what tics are, you'll see them everywhere because they're actually quite common. So up to 25%, and some studies say a lot more, of people will have a tic at some point in their life. And so what are tics? They're sudden, brief, repetitive or recurrent movements and or sounds. And we use the word stereotyped, meaning that they will look a certain way each time. And so we often divide tics into either motor or vocal, meaning it either is a movement or a sound. And we divide them into simple, meaning it's a sniff or a eye blink, sort of one muscle group, a short sound, and then more complex tics, which often look more deliberate or coordinated groups of muscles and or sounds, but are still tics in the sense that they are this recurrent, stereotyped, brief, and sudden. What we know about tics is that they tend to typically start around ages like 5 to 7, could be earlier, could be later, typically start in the head, often the face, head, neck, and then they might travel down and outwards. They typically start motor movement, and they typically start simple and then might progress to more complex. And they often will jump from location to location. You might see eye blinking for a few weeks, then you might see shoulder shrugging, then you might hear sniffing. They're highly suggestible, which is something I think is really important for parents and teachers to know. So a lot of times when kids come to my office and we'll talk about tics, and they'll get frustrated because they'll say, I wasn't ticking, but now that we're talking about it, of course I'm ticking. And that's true. They're suggestible, similar to a yawn. You see someone yawn, you want to yawn. It's a similar way in that the more you talk about them, the more you see them. They tend to increase for periods of time, decrease for periods of time. We don't totally understand why. There's likely a number of different factors that contribute. But another thing that I think is really important for parents to know is just because you see increased tics doesn't mean that there is something definitely going wrong at school, at home, with one's mood, with the anxiety. We know that being more anxious or really having any emotion can trigger or worsen tics, but the presence of them alone doesn't mean that you're missing something. And if they are getting worse on their own, again, it doesn't mean that it might be something going on, but it doesn't have to be. And then the last part that I probably should have led with is in terms of what are tics, we like to use the word involuntary. So they're not voluntary. They're not like a deliberate choice, controlled choice of action. They're not involuntary. They're not happening against one's will. It's not like the person isn't aware or their arm flails or these are happening like to them. It's in the middle. It's involuntary, non-voluntary, more like an irresistible urge, like a terrible itch or that feeling before a sneeze or a yawn. So the person is often aware, not always, but often aware they're doing it. It's just so discomforting and hard to stop that even though there might be negative issues associated with doing it, the difficulty of not doing it is so hard.
I do find when I talk to parents, sometimes they have a hard time telling if their kids are aware that they're ticking.
Yeah.
So for example, they'll be watching TV and moving their neck and shrugging their shoulders.
Yeah.
And the parent will ask them, do you know that you're doing this? And the kid sometimes says yes, but I think a lot of times really they don't know that they're doing it. They're not aware.
Yeah.
And I do find that there are, on the contrary, kids that are definitely aware that they're doing it and very self-conscious that they're doing it.
Exactly. And I would say it's more common than not that kids are unaware when it's happening. It's more that if you bring awareness to it, they should hypothetically be able to briefly suppress it, even if it's for a moment, as opposed to other movement disorders that no matter how hard you try, you can't stop it.
If you bring awareness to it, they can acknowledge that movement is happening.
Exactly. But it's so common that kids, especially watching TV, really doing anything, will be ticking and not realizing. And that's fine. And in those cases, no need to bring awareness. But what you're also talking about is what we call a premonitory urge. And that's like a fancy way of describing a sensory, uncomfortable itch. I've heard all these different words, feeling that the person experiences before the tic. Again, like that feeling before a sneeze or a yawn, that the tic then relieves. And often, on the whole, around age 10 is when you start to see kids reporting having these premonitory urges and then knowing that this is then driving the tic in any particular moment. Younger than that, I have a lot of kids who will describe that. I have a bunch that don't. But what's helpful about that premonitory urge is that if you start to talk about behavioral therapy, you'll use that feeling as a way to work through the different ways to think about trying at least to suppress tics.
That makes a lot of sense. So just to think about the science behind tics, do we have any idea as to why tics actually happen?
Yeah, that's such a great question. Yes and no. We know that there's a brain circuit called the cortical striatal thalamocortical, CSTC circuit, that basically connects your frontal cortex, the part of your brain that helps you make decisions and planning, organization, to the basal ganglia, which is the part of the brain more in control of movement, and then back up to the cortex. And so we know that that circuitry tends to be involved or will look not necessarily atypical, but different than in those that don't have tics on the whole. So we believe that circuit is what's implicated. And there's lots of theories around why you might see different tics at different ages in terms of growth and development and just brain changes over time. And we also know that there's a really strong genetic component. And so I always forget the exact stat, but I think it's about 70 to 80% of tics within tic disorders thought to be linked to some genetic predisposition. What's interesting is that it doesn't have to be that the parents have tics. It's also linked genetically to OCD and a little bit to ADHD, but that's a little more complex. So if you have a parent that has OCD, genetically, you'll be more likely to have a child that might have tics. And if you have tics, same thing, and vice versa. And it's about a 3.5 to 1 ratio in kids of boys to girls. One of the questions that we're often asked, is this going to be forever? Is it going to go away? What's going to happen? And the good news about tics is chances are more than not that they are going to get better as kids get older. So we often see it start around age like 5 to 7. Then it continues off on up till around age 10. And then unfortunately, mainly because it coincides with junior high years and puberty, which is why we think that there's multiple factors and a worsening often between the ages of around 10 to 13, 10 to 14. And then on the whole, as one enters late adolescence, or their later teens, early 20s, you tend to see improvement on the whole, with about a third of people with tics essentially disappearing, not totally, but close enough to none, about a third significantly improving, and about a third continuing, with only about 20% continuing to be more significantly problematic. And for that 20%, it's really hard, and we have treatments and we have strategies and suggestions, but on the whole, that's about 4 out of 5 as they get older doing better. There's some new data saying that for girls, that course, it's still on the whole better as one gets older, but it's less clear that in girls, females, that you're going to see that same dramatic reducing that you tend to see in boys. The rates of those with tic disorders in later teens, adults is more 1-to-1 male to female, and females might have a little bit more complex tics, vocal tics. So I think it's something that we should keep an eye on, but it doesn't change the fact that on the whole, tics tend to get better as one gets older and gets out of those puberty years.
I think that's a very important and helpful reminder that if we do nothing, regardless, the trajectory is positive, that they're likely to improve over time. One thing that you just said that surprised me that I wasn't entirely aware of is that during puberty, tics can get worse. I think what I've noticed in my office is that I'll see a lot of motor tics in particular, that age 7 to 10. And then for a lot of kids that I meet, it seems to improve. And I think to myself, thank goodness, because middle school, those are the years where the kids get teased, they're more self-conscious. So that's unfortunate that that's not the case.
Yeah. And at some point, I just need to speak with a pediatrician. And I've talked to a few parents who I work with that are pediatricians in terms of the correlation with Tanner stages, because it seems once you're more 4 or 5, things are now starting to get better, but it's more
later into puberty.
Exactly. But it's earlier. It's right before the big growth spurts. And again, I learned a word recently at a conference that I like, anecdata. That's more like anecdata. But I think you also do see a lot of kids, 9 to 10, I feel, is the most commonest age to see tics. But then in terms of that worsening, I think for those that are going to worsen, you'll then see it in those couple years after. But just because they worsen doesn't mean they're not going to get significantly better. And that's where it is helpful. I can think of my brother who had tics from a young age that no one knew were tics because we didn't know what it was, that then they sort of exploded, for lack of a better word, age 10, 11, continued to be severely problematic. And I can get into what that means, because having tics itself is not problematic. It's problematic if it causes distress, pain, interference, psychological or physical. So he was experiencing those. And then by age 15, 16, they began to get significantly better. And he still has some that occasionally bother him more than others, but I don't know that if he met anyone now for the last 20 years, anyone would assume that he had a tic disorder.
That's great.
Right. And that's like the typical course, and not for everyone, but I want to make sure parents know, yes, I'm sure it's better if you don't have tics or if you have super mild tics in terms of course, but just even if you do have pretty severe tics, that doesn't mean that things can't get a lot better after those puberty years.
It's great to hear. Okay, so we're just talking about the most common motor tics and the most common vocal tics. So you'd mentioned eye blinking, you'd mentioned grunting, you'd mentioned shoulder shrugging. Are there any other common tics and common vocal tics that you see in your practice?
Oh, yeah, all the time. And again, once for people listening to the podcast, I'm sure if you walk down the street now, you're going to see them like really all the time. But a lot of eyes, a lot of eye movements. So whether it's rapid blinking, eye rolling, which is really important because a lot of kids will get in trouble because teachers or parents think they're rolling their eyes, but it's a tic. Sniffing is a super, super common one. And what's also tricky is that one of the theories in terms of how tics form is just a propensity to overlearn. And so a lot of times someone will get a cold, have sniffles, and then long after the cold is gone, will continue to sniff, which was unfortunately really problematic in the pandemic because many kids either A, developed, sometimes tics develop in a way that it's like, what is something that I don't want to happen? And then the more you think about it, the more worried you are, the more you do it. So there was that, but then also just in terms of lingering symptoms. So in addition to sniffing, coughing is a super, super, super common tic. So a lot of times kids are brought to pediatricians, to eye doctors, to allergists, to pulmonologists for either chronic cough, chronic sniffles, chronic like blinking. And in reality, they're tics. The underlying thing that might have started it is gone.
It's almost like it's become a habit.
Exactly. I think, in fact, pulmonologists call it habit cough, but it's a tic, and it's common vocally. And I guess the sniffing and the coughing, those are counted as vocal tic.
And by the way, speaking of anecdata, I completely agree with you that I seem to experience a flare in childhood tics during the pandemic of chronic coughing, of sniffing, of many simple motor tics.
Yeah. And that gets into so many questions. There is links between inflammatory processes and tics. And in like huge studies of millions of kids in Denmark, Sweden, in those kids that have more inflammatory conditions, more history of infections, strep or non-strep, more likely to have tics. And so there's this, we don't know, chicken or the egg, correlational, it's certainly correlational versus causational. And we think that the same genes that predispose you to having tics are shared with the genes that predispose you to having inflammatory conditions. And so there's this automatic already crossover. And so it's people always question, oh, is those who had COVID going to have more tics? Maybe, maybe not. I don't think it's any different from any other illnesses in respect that we've always coexisted with these, and certain people are more susceptible than others. But I do wonder about that fear component of if I cough, the more anxiety and the more feeling of I really shouldn't do this, I don't want to do this, now I did it, was probably also heightened in the pandemic.
Very interesting. And then as far as you were about to mention simple vocal tics.
So common ones there are humming, actually, which can be tricky and to me is a little different from a typical tic in the sense that it's not brief, recurrent, it's more ongoing. But humming in general, that's, again, I'll probably veer off, but you want, when you have a kid that has tics, you want to be watching for OCD and ADHD. Those are super common in kids with tic disorders. And so with humming, that might also be like an inattentive kind of non-awareness. But humming is a common vocal, and squeaking, and I would say those and the sounds are just the more common vocal tics. Kids get really good at masking tics on their own. And so I'll have a bunch of kids that might have a laugh tic, and then we'll start like laughing or say something so that they're trying to make it look like, oh, that was intentional.
Not as obvious.
Exactly. Which if it works, fantastic. If it doesn't, that's when we can think about treatment. But again, that is going to go back to that main point of just because you have tics doesn't mean it's a problem. It's a problem, and this is something I say to the parents all the time. I don't mind, and you shouldn't mind if the kid has tics. I mind if it bothers them.
I say this all the time to families, and I think it's so helpful to hear you say it, because a lot of parents are concerned, will those movements hurt them physically? You know, for example, if a child moves their head and their neck a lot and really flares their head and neck, and sometimes the movements can look forceful, and
Right.
parents worry, are they going to be hurting themselves? And so what you're saying is it's unlikely, correct?
Exactly. It's not impossible. And I think there's a very, very rare, particularly like with neck jerking backwards, that we try to keep an eye on. But I would say that's the exception rather than the rule. Parents are always super worried that they're hurting themselves. And one thing that is probably underreported and underasked about is pain in Tourette. But again, that's the subjective experience of the person. If someone is jerking their neck a lot, it can get sore. It does get sore. And then we speak about ZEDs or heating, compression. But it is extremely rare that I'm worried that they're actually going to hurt themselves because of the tics themselves. Not impossible, but now we're talking like those are kids that are experiencing tics to that degree are by that point almost certainly seeing neurologist, psychiatrist. Like this, it's if you're asking your early line pediatrician, I'm not worried. What I should say in terms of the vocal tics, when people hear Tourette, they think corporalia or swearing, and do not have to have that to have Tourette. All Tourette syndrome is 2 motor tics and 1 vocal tic for at least a year, off and on, coming and going. It is very easy actually to meet the criteria for Tourette syndrome. It used to be that you had to have impairment. They got rid of that criteria many years ago. And so I think Tourette, it's cited around 0.5, 1%. Other chronic tic disorders, another 1 to 2%. It's probably higher if you eliminate that distress criteria, because again, all you need 2 motor, 1 vocal. About 15 to 20% of people with Tourette will have corporalia. And for them, it is hard. And we speak about treatments, but I really want to separate the difference between a single symptom that some people have and the vast majority of people who don't have it. And just because you have Tourette does not mean you're going to develop corporalia.
And 2 quick questions there. For people that aren't aware, what is corporalia?
Yeah, so corporalia is, I won't try to translate Latin, but basically obscene words, swearing, racial slurs. That's what we mean by apraxia, is obscene movements. So that might be the physical, the motor tic component. So raising one's middle finger, doing like thrusting motions. And so those are often linked. It's not uncommon if you have one to have the other, but those are some of the more, probably the most severe tics in Tourette.
Absolutely. Yes, that must be so stressful for the parents and for the child. And then next, just to quickly paint a picture for somebody what it might look like if somebody has Tourette's. When you say 2 motor tics and 1 vocal tic. So I'm picturing a child eye blinking, grunting, and then humming. Would that be an example of someone with Tourette's?
Yeah, I guess if you count them separately, that would be 2 vocal, 1 motor. But yeah, a Tourette diagnosis could be as simple as blinking, a few shoulder shrugs, and sniffing.
Makes sense. Okay, so we've got 2 motors, 1 vocal.
2 motors, 1 vocal. It's, again, like to make a sound, you need to move muscles. And so there's a push to separate this distinction between motor and vocal, because it's a false distinction, but at least for now, that's the way. And again, you could have them when you're 5 for a couple months and then nothing. And then when you turn 6, have a few more. Like, it counts. That's why I really think it's the rate of people who meet criteria for, quote, Tourette syndrome is probably a lot higher than we think.
I definitely would agree with that. And I agree with what you said before, that once you start noticing them, you notice them all the time.
Yeah.
I probably think is a good thing that most people don't notice them so much.
Or like the fact that one of the big takeaways is kids with tics are normal kids. There actually is some like links perhaps about like brighter, more creative, quicker, like it has positive attributes, witty, that have been associated. I won't try to explain why or how other than it's shown up, but like a ton of successful people with tics, you just don't know that those are tics until you know what to look for.
Yes.
which is interesting.
Yes. I'm thinking, particularly for spouses out there who think maybe their husband or wife has an annoying habit, it's not their fault. A lot of times
Yeah.
it's just that vocal grunt is just a tic.
Exactly. Yes.
They're not
Yeah.
doing it to annoy you intentionally.
Exactly. And bringing attention to it, unless they're in treatment. And I can talk a little bit about treatment, CBIT, Comprehensive Behavioral Intervention for Tics. But unless the person is explicitly working on the tics with a plan, you telling them to stop it is not going to help. If they're an adult, they might not know they're doing it, but if they do, does telling anyone to stop,
Yes.
that would be, if only it were that easy,
It's likely to make it more stressful.
which is going to increase tics. And parents will also think tics are like anxiety driven. They're excitement driven too. They're really anything that keeps you off of your sort of like copacetic status quo can exacerbate tics. So the story is always like going to Disney World for December break and happy place, lots of excitement, lots of overstimulation. Tics might go off the chart and then come home and then they might go back to typical level.
I'm glad you bring this up because I do meet a lot of parents who want to help lessen their child's tics, which I understand, and they worry that stress plays a component in worsening their tics. And so they'll do whatever they can to make their child's home life, social life, personal life as least stressful as possible. But then I think it's not real world. If you think about it in the lens that the tics aren't hurting the child, it's not real life.
Yep.
If we really are trying to do everything to decrease their external stimuli at the expense of lessening their tics, they're
Yep.
not going to be living their life. They're not going to be engaging socially. They're not going to be trying their hardest in school. And I think overall it ends up being not as helpful for the child as we would think.
Yeah, I think you hit the nail on the head. And that's like with the CBIT therapists I work with, that's a message that they really want to drive home. That's negative reinforcement. So if you're having a lot of tics and now you're having a lot of tics so you don't have to do your homework, well, that's not going to encourage you to not tic. You really have to watch out for taking stressors away, inadvertently exacerbating the system. It's really, the goal is to do what you do normally, what you enjoy doing, and keeping expectations just as you would keep them if they didn't have tics. There's always caveats, there's always exceptions, there's always periods of time where, maybe for these few days or weeks while you're changing something, it might be a little different. But on the whole, the goal is not to just reduce stress in the environment. It's not real. And you're just kind of setting up for further problems down the road in terms of anxiety and just more negative reinforcement patterns.
It's all so interesting because I do think a parent's natural inclination when you see your child ticking is to tell them to stop. You want to help your child, but it sounds like parents intervening for the most part isn't helpful.
Exactly. The more you can calm ignorance or ignoring, if you can't, ignore. The less attention, the better. Positive attention, negative attention, both continue the cycle of increased tics.
So I have parents that I've met who swear that they've told their child they have to stop and that's worked. So I'm just curious, from your perspective, is there ever a situation where a parent should bring up a tic to the child and tell them to stop? Or is the general advice that it's best to ignore?
Best to ignore. I'm sure if I racked my brain, I could think of a situation. It's tough to think of a situation that the child isn't already aware that a parent telling them to stop is going to be helpful. Tough for me to believe that a parent telling a kid to stop actually caused the tics to stop. You can suppress them for periods of time, and that's what the therapy helps you work on, but each tic is unique. And again, if it were that easy, people would do it. So what I could also imagine is the tic jumped, it came and went. Just because you treat one tic doesn't mean it's going to pop up somewhere else. They all have their own kind of rhythm. So that would be more my guess, that after a few weeks of saying stop, the tic was probably going to go away on its own.
Yeah, I have to tell you, my mother-in-law who listens to this podcast, yesterday I was telling her about the topic of today, and she said, when my son had a tic, I just told him to stop, and it worked.
Yeah, I always say never, but
Never say never.
No, that would not work. Vast majority / all the time.
Okay, so in terms of kids that are more at risk for developing tics, you mentioned genetic predisposition, males are more likely than females. Any other group we should think about that is more likely to develop tics?
Ooh,
Two
you
big
know
ones.
what? It's a great question that I probably have to think more about. We know that they're more common in certain ethnic or racial populations. So I think French Canadian, Ashkenazi Jews, they're still prevalent across the world. It's not, it used to be thought like not in sub-Saharan Africa. There's a few papers that say that's not true. They're represented all ethnicities, races, but there's certain ones that are perhaps more likely to be expressed. But other than that, I mean, again, the other like really big takeaways, less about which cohorts, but more the real reason you want to pay attention as a pediatrician if you see a kid with tics is because of the comorbidities. And the comorbidities are actually often what's more problematic than the tic themselves in kids with tic disorders. And again, a lot of these comorbidities are all associated with that cortical striatal thalamocortical loop that I mentioned earlier. And so ADHD and OCD are the two most common, but you want to watch for anxiety, ASD, not necessarily full ASD, but some symptoms, which that's a whole topic onto itself in terms of overdiagnosis, particularly in those with Tourette, but it is more common. Certain learning disabilities, impulsivity, which goes with the ADHD, disinhibition, body focus, repetitive behaviors, hair pulling, skin picking, sensory hypersensitivity. I'm sure there's a few I'm leaving out. And again, it doesn't mean that if you have tics, you will have all of those. It just means those are the things you should be keeping an eye on. Tics have their natural course, to our knowledge, regardless of whether we intervene or not. Those other conditions, if you don't, can continue to get worse and develop into further conditions. Yeah.
I think the point that you're bringing up is a great one. Big picture, the tics themselves are not harmful, but being aware of the tics is important because it may also draw your attention and awareness to other conditions that are related to having tics, and that can be very helpful.
Exactly, and that's where you should and can intervene. What I will say about tics is that in a lot of surveys that the Tourette Association of America, I don't know if I have to disclose, I'm on the medical advisory board, I don't get paid, but they have great resources for kids, for families, for schools, great informational packets. But they did a study on the impact of tics on kids, and the biggest problem, if tics were a problem, was the impact on school. And so we really recommend, if the child has simple tics and they are not bothered, you don't need to bring it up to the school. You shouldn't bring it up to the school. If tics are starting to get in the way or those co-occurring conditions, it's really important to work in the school. And a few times I'll be at lectures where one of my colleagues is basically giving a talk and saying, okay, when you have to write the Pledge of Allegiance, and every time, you have to count to 4, and whenever you count to 4, you have to blink, and now try to write the Pledge of Allegiance. It's distracting. It can be really hard, whether that's OCD or tics. The point is that there's a lot of things that get in the way of being able to pay attention, in addition to the fact that there might be ADHD for those with tics. And you don't want kids to be double punished, which I think of as if the tics are bothering them and now they're being punished for the tics. That's even worse. And so working with the school so that the school doesn't point them out. They don't sit them at the front of the class, perhaps the back of the class, or wherever the kid feels most comfortable. They can take movement breaks if they need to. If they have vocal tics, letting them chew gum, have an extra water bottle to help maybe mitigate some of the tics. But it's really like bullying and problems in school are some of the biggest problems that we see. And we just need better intervention and better understanding.
So I'd love to ask you about treatment, because this is a big question that parents have. So I agree that for most kids, it's important to ignore the tics and watch the natural trajectory. But when is the time when we should be recommending interventions? You had mentioned CBIT, CBIT therapy, and I know there are also medications that may come into the picture. So what is your recommendation from that aspect?
Yeah, so right now we're thinking like, what do you do if it's an issue? So again, like how we're defining an issue that needs help is if it's bothering the child psychologically, physically, socially. And that's when we're thinking treatment. CBIT, Comprehensive Behavioral Intervention for Tics, which I won't go into the details, but it's essentially a behavioral therapy that helps kids recognize the feelings that they have before they are having the tics, and then develop either competing responses or other strategies that help to then reduce the tics. And it's hard, it's work, but that's always our first line treatment if someone can find a provider that does it, which is tricky. Again, TAA has lists and resources, but it's a very specific treatment. It's not just don't do that, do this instead. It's more involved.
When you say that's first line, you mean that's your first choice before
Yes.
initiating a medication.
Exactly. But it's hard to find and it's not always possible. And a lot of times kids don't want to do it, which again, it's tricky because if it's a treatment that you need to be active in. So if you're not going to do it, it's not going to work. And then you don't want to create an environment where the parents and the kids are yelling because the kid isn't doing the treatment to help the thing that's already hurting him. And it just turns into this like problematic mess, which again, it happens and you can work through it, but not everyone wants to do CBIT. And so then we start thinking about tic medications. The first line medications we almost always use are alpha agonists. Clonidine, guanfacine. Clonidine has a little bit more evidence than guanfacine, but no reason to not try both if one doesn't work. And what's also interesting and important, possibly from a pediatrician's point of view, is that the alpha agonists are a lot more likely to work if there's co-occurring ADHD. And we know that they're also a treatment for ADHD, and those are both involved in that circuitry. And so it's a little bit of a two birds, one stone. But the other really, 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 really important takeaway, again, a lot of kids have tics, have ADHD. You can use stimulants to treat the ADHD. It used to be said that if there's ADHD and tics, don't use stimulants, it'll worsen the tics. Does it in a percent? Probably, yeah. But in huge studies, not more than placebo and or not for more than a very brief period of time. And in studies that combined alpha agonists and stimulants for kids with ADHD and tics, they did the best. And kids in the combo group, the alpha agonist group, and the stimulant group all did better, or at least not worse, I think even better, than placebo for tics. So
That is so interesting because that was always my teaching. If you give a child with ADHD a stimulant who already has tics, you're likely to make the tics worse. And that's something that you have to make the parents aware of.
Right.
So what you're saying is that we should not be dissuading them from a stimulant if that really is the best medication for them.
Exactly. Like it still might be worth trying clonidine first if there's tics and ADHD, but if it's clearly the ADHD is the issue, yeah, you don't want to not use a stimulant for concern of tics.
And I'm curious about CBIT. Do you have any statistics on the likelihood of it improving the tic symptoms?
Yeah.
Of it improving the tics?
At least in the moment, because again, like new tics might come and go, but the principles will be the same. But I think it's the effect size is around 1.2. What I can say is that after alpha agonists, the next line, this is where we need more medication and better medication with low side effects and high efficacy. And there's some coming down the pipeline that I'm really excited about. But after that, it's antipsychotics, dopaminergic agents, things like aripiprazole, risperidone, and CBIT is shown to work equally to those when done well.
And between the two, does one have more staying power? For example, I wonder if treating with a medication is just a Band-Aid or does it actually fix the tics?
I would say none of them fix the tics because in general, like none of our treatments are like quote unquote like disease modifying, but and there has to be better studies or more studies on whether they combine. It's tough to imagine combining wouldn't be helpful, but they haven't done all the research to officially say that. I do think CBIT is great just in terms of strengthening, like probably helps with, I can't say that either, whether it helps with executive functioning or not. But in general, you're teaching yourself tools that you can use that I'm sure are only helpful, but it's not that it would necessarily prevent new tics from coming. You would just be able to use those strategies. Similarly with like clonidine and those medicines, it's not that they're going to stop new ones from coming, but you still might have that as a suppression.
I guess a big question that comes up for me a lot in clinical practice is parents want to know when should they be making these interventions.
Yeah.
And I've always learned with CBIT, for example, what I've learned, and I'm curious your thoughts on this, it's most effective when there is that premonitory urge, when they know that the tic is going to happen and they have the ability to make a change. in place of that tic.
Yeah.
Is that your thought as well?
I would say on the whole, it's certainly much more helpful, but also, even if they don't have, that's what they would do with the therapist, the work, in terms of understanding what those triggers are. So that's why it's helpful, but I'd say not necessary. And I wouldn't recommend CBIT if the kid has mild tics and isn't bothered. Again, we don't have evidence that doing that is going to change the course. It'll help in the moment if it's helping and if the tics are bothering someone, but it's not that if you get them into treatment, we know that's more modifying.
As I think about it, as we're talking about this, the most common scenario I see is that the child really isn't bothered by it, but the parent is bothered by it.
Yes.
So you're saying that in that situation, the CBIT may be helpful, but not as helpful should the child be the motivating factor to starting the CBIT therapy.
Exactly. If the parent is bothered and the child isn't, I would not recommend CBIT because you're setting yourself up for problems down the line, and they might get better on their own, and they should.
Well, thank you so much. This has been so helpful. Just to close, any last words of reassurance that you'd like to offer?
Yeah, on the whole, I always say to parents, time is on your side with tics. The older you get, in general, the better they tend to get. And most kids with tics are doing well. They're doing fine. The more we react to them, the harder we can make it. And then lastly, I'd say tics are something that a child has, not who they are. And just acceptance too is often best, both for the kid, for the relationship, for the future.
Thank you so much. And can parents see you if they, is there any that parents can schedule
If they're
a visit
in
to
New
see you?
England, yes. We have a bit of a wait list and we have a group, which is awesome. But yeah, if you go to the Mass General website and either Google my name or like Ped Psych Tics, our program should come up. And then there's always an intake that they can fill out and then see me or one of our great clinicians.
Dr. Greenberg, thank you so much. This has been such wonderful information, and I so appreciate your time. Thank you for coming on Your Child is Normal.
Yeah, you're welcome. Thank you for having me.